Hi, I'm Justin Lichme of HappyNeuron Pro, and today with me I have Dr. Marianne Keatley in Denver, Colorado. Marianne, it's lovely to have you today.
Thank you.
So can you tell me a little bit about your private practice and what you do?
Well, I've had a private practice for over 30 years. I worked first in inpatient rehab for 13 years, and then I moved into private practice, and I primarily do evaluations and treatment of individuals with brain injuries. It turns out that most of the clients that I see have mild to moderate traumatic brain injuries. Some have severe injuries and they're a little farther, post-injury by the time they get to me. But like in Colorado, we have Craig Rehabilitation Hospital that does a lot of the acute care. And then the patients come to us after the fact. And so we spend a lot of time working on getting people to develop underlying cognitive skills like speed of processing and multi-track thinking and language and word retrieval. And then we also do functional symptom questionnaires with patients so we can correlate the problems that they feel like they're having in day-to-day life. And then we do tasks to remediate those or at least help them compensate.
And what are the common cognitive complications regarding language that you see in people that have traumatic brain injury?
Language is really complex in terms of traumatic brain injury. A lot of times people will have an injury, even a frontal injury, and it will affect the left hemisphere, Wernicke's and Brocau's area both. And so you'll get just word retrieval problems. Sometimes it's very specific, like you'll get only problems with nouns or only problems accessing verbs. Sometimes I see patients that have neurogenic stuttering behaviors with accent problems. We see clients that have pragmatic language problems, and there's some great little programs on HappyNeuron Pro that work on that, some of the paper pencil tasks. So pragmatics and general word retrieval or losing their place in conversations. So those are a few of the language ones.
And then when you're working with the clients, what are some assessments that you do before to see how their cognitive functioning is before you start treatment?
Right. The one that we use and is used in a lot of outpatient hospital settings around here is the Woodcock-Johnson Psychoeducational Battery, because it looks at, like 12 different areas of functioning in patients. So you can look at long-term memory, short-term memory, speed of processing, logical reasoning, a whole variety of things. And then we always pair that with a functional symptom questionnaire. I would say a majority of the patients that come have had full neuropsychological evaluations. So we can also use the results of those to develop a treatment plan.
As a speech language pathologist, is there a certain neuropsychological assessment that tells you more about a client and their functioning with language than any of the other ones? Are there any favorites that you have that you use commonly or that you like to refer to when diagnosing a patient?
Well, there's not a lot of higher level language kinds of neuropsychological batteries. Most people use the controlled oral word association test, which works more on phonemic naming. It also has a semantic naming for categorical words in that. Some people use the Boston, but that isn't really quite as high level as most of our patients.
Right. And do you do any work with the cookie theft task?
I'm sorry, with the what?
The cookie theft task?
No, I don't think so.
Okay. Yeah, I know it's very common for stroke and dementia, but I don't know if you use it for TBI. Basically, what happens is the patient has to look at the situation where there are a lot of things happening, and they have to describe the situation in as much detail as they can, but also in a way construct a story. And I'm sure with the issues that you see in TBI, that would be very challenging for some of them to do.
Exactly. Although there is a test called that we used before, and we use it some now, called the picture story language test.
Okay.
That's, a functional picture, and it has a lot of elements, and then people explain it, and then we can analyze it based on productivity and linguistic structures and things like that.
Very cool. And can you tell me, when you start working with clients, do you have an average amount of sessions that you see patients for before discharging them?
It depends entirely on the level of their injury. Dustin, when you see people for the first 90 days, that's a period of rapid spontaneous recovery. Some of our patients come within a week of injury, and some are coming as much as 8 to 10 years post-injury. So it really depends, but the average number of sessions of cognitive rehab for somebody with a mild traumatic brain injury is about 30 to 50. And so it's quite a lot of sessions. We don't always see people that long, but, and there's ways to cut down on that by, say, for example, if people will do computerized cognitive rehab tasks, they can do a lot of their own rehabilitation.
And can you take me through what a standard session would look like with you? Just your average
Sure.
that has the TBI.
Yeah.
What happens?
What happens? Okay, so we see people for about 60 minutes. Some people do less, but we do 60 minutes, and it's just about enough time to fit everything in. But we usually start the session reviewing what homework they did last time, or if they're doing computerized tasks, what they've been working on, how they've scored, what level they need to move to on those tasks. And then the sessions are designed. I usually start with 3 areas to work on. So let's say it might be language and word retrieval, logic and deductive reasoning, and speed of processing. And then I develop tasks, obviously within the realm of what somebody can do. And about the first 10 minutes of each session, 10 to 15 minutes, the tasks are chosen so that the patient can perform at close to 90 to 100% accuracy. Then the second 20 minutes or so, we're hoping that people can function within the 50 to 75% accuracy. And then the last 20 minutes, of course, then we increase it so that there's a feeling of accomplishment in the last period of time. But based on the client, 15 to 20 minutes is spent on each of these 3 areas.
And then I know that you've been using our program for quite some time. What made you decide to assign your clients home exercises? And then what is your protocol for doing so?
Uh-huh. Well, actually, and this is going to date me, but you can already tell by looking at me that I'm older, way older. No, seriously. But what that gives me the advantage of having used these programs. We all, in hospital settings, in the 1980s, about 1985, started using computerized cognitive programs. And they're much more perfected now. Like your HappyNeuron Pro program is very, a little bit elegant, because it actually pinpoints areas, and then it gives really strong stimulus items. And that's how you actually see, for example, build in a memory function, is by having a very strong stimulus item so that neurologically the person will see it. But I started using cognitive retraining for various reasons on the computer, because number one, some people like it and that's all they'll do. Seriously, people come and say, I don't want to do anything else, that's it. It allows you to watch what the patients are doing, how they're doing it. You can track it online. It's good if you're in the process of doing litigation, because then you have all the information there. You can also, the person can work independently, which is very important. And I think that computerized programs are really the only way to, well, I shouldn't say the only way, but one of the most efficient ways to improve speed of processing, flexibility of thinking, and like on HappyNeuron Pro, I think it's called 2 timing. I know it because I use it all the time. 2 timing is the one that's auditory memory. And a lot of programs don't really have auditory memory, but some of the computerized programs that have those are excellent. So those are primary reasons that I've turned to using it. It's not the only thing I do. And I do like the paper pencil tasks that you all have. We use paper pencil tasks as well.
When you assign your clients homework, what results do you see with them as a result of doing the home practice?
Mm-hmm. I see a lot of improvements in their speed of processing, their multi-track thinking, their flexibility of thinking. And one of the things that's also good about HappyNeuron Pro that I've noticed in relationship to some other programs is that you add the element of functional performance. And I think that's what we begin to see as people perform more functionally.
And can you elaborate a little bit more about that? What do you notice and how do you see people improving functionally?
Well, it's pretty interesting. Like your programs, some of your language programs like split words, and some of those are a little bit harder. They're a little bit higher level. But when patients do these on a consistent basis, they can retrieve words more easily in conversations. Some of them, the travel ones, like 80 Days Around the World, and some of those, that's very good for decision making if people are actually out in the world, like trying to plan bus routes or, recall information for, of salient markers out there. So I see a lot of functional improvements.
In terms of connecting the work that you do with your clients to their everyday lives, what practices do you use to help foster generalization?
Well, like with our clients, they'll outline specific problems that they're having in their functional environment, like let's say balancing their checkbook and making sure it's accurate. And so by teaching them how to inhibit certain kinds of rapid responses. And that's what some of the computerized programs do beautifully, is they teach people about their lack of inhibition. So it teaches them to self-correct errors. It teaches them to inhibit those responses so that they're not making those levels of errors. So that's just one example, but there's a lot of things that these programs work on.
And do you work on any social functioning with your clients that have TBI?
We do. We definitely do, like pragmatic skills, like paying attention to expressions that people are making so that they can follow. Is that person, are you losing that person? Because as you know, with traumatic brain injury, a lot of times there's poor pragmatic skills and people go on and on in conversations, but we try to teach them, okay, stop. Watch that. And some of the programs and some of the paper homework that you guys have work on identifying what expressions are and what they mean.
And in working with your clients that have TBI, what psychological problems do they experience as a result of their injury? I know very commonly a lot of people with brain injury do experience depression. Anger management is a big problem, stress and anxiety. Do any of your clients experience those or maybe other psychological disorders as a result of TBI?
Yes, definitely. Those are huge problems that people deal with. A lot of times it is depression. It's a biochemical depression that occurs, and also anxiety, obviously. And because lack of sleep and things like that, it also exacerbates all of those problems. But interestingly enough, I'm also certified in Eeg Neurofeedback and have been for many, many years. And so I can do brain maps of where people are, and then we can begin to work on changing brainwave patterns and things like that will address that. But the thing that's really interesting is that over the years, I've gotten many referrals from psychiatrists, because when you're using computerized cognitive rehab, you can increase beta levels, which correlate with pulling people out of depressed states. So if you can teach them that, that really helps them learn how to voluntarily move beyond that, even though some, require medication.
Right. And I'm not sure what the status is like in Colorado, if you guys are able to see patients in person. But before COVID, were you combining the cognitive training with the neurofeedback?
I've done that for years. Yeah, I've been certified for many, many years. And I did that. And it's funny you should ask that. We can see people in person now, but what I used to do with clients is I would hook them up, like say, for example, if we were working on focus, concentration, and attention, I'd do a C3, C4 placement. And then I would have them I would take a baseline, and then I would have them do a computerized cognitive program and see how that pulled them up into alpha or beta at that particular site. And so you could correlate, brainwave functioning with performance.
And what do you notice as a result of combining those two methods? What does that tell you? And then how do you use those results from that session to inform your treatment later on?
Well, it's actually a beautiful combination because patients can see, they can watch their brainwave frequencies and patterns online, and they can correlate it with what's the task they're doing, and they can see progress. Like, if you're doing language and word retrieval, you would do the left hemisphere, put electrodes there, and then you could work on specific language tasks, and then you could even work on language tasks on the computer. And they could see like, oh, if I'm doing this kind of task, this is what I'll get. And if I'm doing split words on this program, this is what I'll get. So they could really see the carryover, and it motivated them to do more work and practice the programs more consistently.
Cool. And with your clients, while you're doing these EEG and these cognitive training sessions, what happens when you notice that a client's getting fatigued?
Well, it's actually a perfect learning tool because cognitive fatigue is a huge factor for the clients that we see. And we spend a lot of time in the beginning working on executive functioning and energy allocation, like having the patient assign a certain level of energy to particular tasks, like does it take 50% of your energy to go to the grocery store or whatever. And so the beauty of having EEG and then computerized tasks together is that they can see if they're doing a certain kind of task, how long their cognitive energy will last.
And that's interesting that you talked about the breakdown of the energy. What strategies or techniques do you have to help them understand that? Is there a way that you visualize the energy levels for different tasks?
Well, yes, actually, I mean, it's the energy level for specific tasks, and it's mostly multi-stimulation tasks, like going to the grocery store. You've got light, you've got sound, you've got all that visual stimulation. And so some of the strategies we start with, of course, are compensatory strategies of, okay, how do you compensate for this? Well, you put in ear filters, ER1525 noise dampening ear filters. You get a baseball cap, you wear your sunglasses, and then we would set up for all the specific grocery stores in town. We got the layouts of the stores from the managers, and then we could mark the aisles and then set up grocery lists for our patients where they could go specifically aisle to aisle.
Very cool.
Yeah.
So it does help them live independently.
Yeah.
And going off of that as well, I'm sure a lot of patients with TBI, have partners or they have friends and family members, but as a result of their injury, they have behavioral issues that can impact those relationships. What issues do you notice in your clients that have TBI? How does that affect their relationships, and how does that affect their families and their lives themselves as individuals?
Yeah, it's very, excuse me, it's very debilitating because when there's couples, partners, most of the time the functional home tasks have been divided. Like you do all the bills and checking and things, and you do all of the decision making for travel or something like that. And what you find is that it's all moved over to one person for a period of time. We work a lot in interdisciplinary situations, like there was always a psychologist in my office. So that person, we could move the client over and say, help this family understand this. But by educating the family about the very specifics of brain injury and their partner in particular, you can really allay some of the problems. But clearly you mentioned them: anger, frustration, cognitive fatigue, inability to follow through. And I do a lot of upfront things like check all the checking accounts each month, because we used to be able to get the banks to take off those charges for checks that bounce and things, and they won't do that any longer. So we've got to use a lot of prediction skills ourselves to help the families.
Right. And what kind of strategies do you have the client work on with you to help maintain and rebuild those relationships in their lives that that are currently damaged as a result of their brain injury?
Yeah, it's pretty complex, but I think reassuring the family that in traumatic brain injury, you're going to see improvements. People improve in a stair-step recovery curve, which is obviously quite different than a stroke, where you have rapid improvement and then you get more stabilization. In brain injury, you get the stair-step recovery curve that occurs over long periods of time. And many of our clients can return to work, but sometimes it's 5 to 6 years post-injury before they have the stamina to do that. And so we work with the families to try to, make things as easy as we possibly can, come up with efficiency systems for bill paying and managing household tasks. We bring teenagers in. A lot of times the kids are so helpful. I mean, people wouldn't say that just in your everyday life, but if you bring teenagers in and say, this is your parent, this is what's going on, and we need you to do this. You have to be very specific about the tasks, but those are some of the things we do.
So it sounds like there's a little bit of family restructuring in a way that you work with the client and the family.
That's correct. Mm-hmm.
Very cool. So oftentimes when someone has a brain injury, their first thought is, oh my God, my life is over. It's never going to be the same. Would you say for a lot of people that there is hope after TBI?
Oh, yes. There's so much hope. I just dealt with that yesterday. I had a long distance call from someone in Montana, and she was like, I just can't live like this. I don't want to live like this. And I told, my other doctor, well, that other doctor had never treated brain injury before in the remote area where she was from. And so we had a big, long talk. She's only 4 months post-injury. So she's going to get a lot better. But that's, hope is so important. And helping people find resources, monetary resources, and things like that can be very relieving to them.
And what are some resources that you advise all clinicians to connect their clients with that have TBI? What are some things to look out for in the community?
Yeah, there's so many things that go on. I mean, not as many as we wish, but like the Brain Injury Association of Colorado. Also, the National Brain Injury Association is excellent. They have a lot of resources. We keep lists of resources for our area. So food banks, and there's people that will help with taxes. People who specifically will volunteer their time to help with taxes. The emergency energy assistance programs in the state of Colorado, at least. But there's a lot of resources for things like that.
Very cool.
Yeah.
And can you tell me a little bit about your treatment philosophy in regards to speech-language pathology and TBI?
Yeah. Well, our philosophy is that you treat everything functionally. And we have a lot of people that we can refer to: vision therapists, psychologists, nutritionists. And so if somebody has a specific problem that really needs more intricate treatment, we send that person out. But our philosophy is to do as much functionally as we can to get people back to work or functioning in the home environment, cooking, being able to cook recipes and do things like that are just critical. And sometimes it's the work, obviously, of the occupational therapists, and there's people that go into the home. Sometimes we go into the home. COVID has made it a little bit more challenging, but we do a lot of functional activities.
And what is the name of your private practice? Because I don't think we ever got that.
Yeah, I know, probably not. It's just my name, Marianne Keatley,
Okay.
PhD, Thomas CCC. Yeah.
Very cool. And I know that you do a lot of work with the Brain Injury Hope Foundation. I'm wondering if you can talk to me about what started the foundation, what your role is, and what the foundation is about.
Sure. The Brain Injury Hope Foundation was started 23 years ago. And I started it along with a social worker in town because we kept having clients that were homeless. And these people had been very successful prior to their injury, and they were labeled as having a mild head injury. But a lot of times they couldn't do their jobs and they couldn't work, and they had been fired or lost their company. And so they were sleeping in their cars, they didn't have food, which impacted their ability to recover. So we set up the foundation specifically to provide funds for food, rent, and utilities, just those three basic things. And then in the state of Colorado, we used to have something called the Brain Injury Trust Fund. Our first name was the Trust Fund, and then it was changed after somebody else took it over. But we were getting money. We legislated to get money from drunk driving tickets and speeding tickets, which provided a lot of money. And then people could use that in specific amounts for treatment. People were given a couple $1,000s a year. That has since, gone away. That doesn't exist. But we still help people get into apartments or get into living situations. We provide money for food. We provide money for heat and electricity if they don't have it. And we provide money for people for several years. So in order to apply for the funds in Colorado, we'd like to have other states set this up. We're only doing it in Colorado, but having other people set it up so that some of their survivors can get funds and resources to do things. We also provide computers to people through something called a computer connection, so people can get computers to work on. And we also provide a monthly survivor series, which has a specific topic. This month, last week, it was on vision issues and disturbances following brain injury, and it was excellent. We always get about 100 people. It's free. You can sign up online through the Brain Injury Hope Foundation, and we love that. So we get people from around the world really coming.
Cool. And are there ways to donate or get involved with the Brain Injury Hope Foundation?
Yes, actually, it's great. We love volunteers and we love donations, obviously, because it really helps. You can go onto the website and there's a specific button you can hit to donate, and you can donate funds. And since we're a 501c3, you can write it off on your taxes. And some people give stocks, some people give other things, but it's a great partnering with the community.
Very, very cool. And can you talk to me a little bit about how maybe other states can set up a similar program in their state?
Sure. I mean, I started this foundation with, actually, there were a group of women, 6 women, and they wrote this little book, a little tiny handbook on brain injury. They all had had a brain injury, and they decided they wanted to publish information for patients. We still have it. But anyway, they made $600 after about 6 months, and they gave the money to me to start the foundation. So I started the foundation. We got an attorney and a couple of physicians and social workers and other people, and we formed a board. And we took that money and we set up a corporation, a 501c3, filled it out, and then we send out, say, for example, a donation letter at Christmas time, a postcard here and there, and that's how we get funded.
Very cool. And just thinking about the people that you see and their brain injuries, what are the common causes of brain injury that you see when you have clients that come to work with you?
Well, the common causes that we see primarily are motor vehicle accidents, slip and falls, sports-related injuries, like bicycle or skateboard, mountain climbing. Those are fairly typical. There are other kinds, obviously, of brain injuries, and with COVID, we're already getting a number of calls from people who, have all kinds of symptoms associated with that.
Can you talk a little bit about that? Like, what do you see with people that have had COVID?
Yeah. With COVID, we're seeing a whole variety of things related to memory, slow processing speed, significant cognitive fatigue, some word retrieval. But there's, those folks are called long haulers, and some of them have had symptoms from kind of the beginning and they haven't resolved. We're seeing people with problems around, oddly enough, dizziness, balance. A fair number of those are symptoms, and so we send out to vestibular therapists, but we have to pay attention to that.
And do you think that's due to lack of the oxygen getting to the brain? I know breathing is a very big problem with COVID.
I mean, clearly that's something that's very contributory, but it's kind of an interesting symptom, whether it's visually related or, related to the hearing mechanisms or what's creating that. Right. But it's going on for quite some time.
And do you have a difference in how you treat people that had COVID-19 versus people that have had TBI?
Well, I don't think we know enough yet to know. I mean, we can provide some basic stimulation to start to hopefully increase, blood flow into the cerebral areas. But it's hard to know exactly what's happening yet. I'm sure that pretty soon you're going to find that there's a lot of electrical things going on and that maybe EEG neurofeedback will be the key. But I still think that a lot of the computerized programs on speed of processing are going to be critical for these clients.
Very much so. I know there have been some reports as, last year when we were learning more about the virus and how it impacted people, many physicians were saying that their clients had neuropsychiatric problems due to brain oxygen levels, due to the virus impacting the respiratory system. Another thing that I want to touch base upon was in your practice, I know that you do work with a psychologist and you have some other therapists that are in that practice. Can you tell me about the situations in which an SLP would work with a psychologist? I think a lot of SLPs are often on their own and maybe don't know how to do that.
Right.
There are times an SLP might want to consult a psychologist when working with a client.
Yes. It's really so integral to our practice because when a client comes in, a lot of times when I see somebody for the first time, let's say they've had the average time, I can tell you this, before people get diagnosed in Colorado is 14 months post-injury before a diagnosis happens. Yes, it's very scary. And so by the time somebody's gone through a lot of initial phases and feels like they may not recover, and they come in and a lot of times they're their mood is very destabilized. They're crying, they're weeping, they're depressed. And if that's the case, and I see it right up front, I bring in a psychologist into my office. Sometimes I'll leave then for a few minutes, but they can actually really talk to people and stabilize them during that time, give them some understanding of what's gone on with them psychologically. And it's helpful. Like, I just saw a patient this last week who I've seen over the period of almost 2 years, and she's been doing really great. And then an event occurred. I mean, she's working and everything, but an event occurred that destabilized her. So I immediately got her to see a clinical neuropsychologist that specializes in brain injury. And I think, Dustin, one thing that's really important is if you're going to send clients to different rehabilitation professionals, is just make sure that they have experience with brain injury.
And what exactly does experience with brain injury mean? Because I think a lot of people might think their standard, maybe a concussion patient where it's very light damage is sufficient. But what, in your experience, defines having quality experience with TBI?
I think having quality experience is someone, a practitioner that understands the symptoms of brain injury. And sometimes I'll see somebody in a remote part of the country or even in a remote part of Colorado. And, I did write a book called Understanding Mild Traumatic Brain Injury quite some time ago. And it has it's very simple. It was designed for clients and practitioners that don't know much about brain injury, but it lists the symptoms and it lists all kinds of things like cognitive fatigue. If you go to a psychologist that doesn't understand brain injury and the person's not working, they may think, well, you just need to get back to work. But the cognitive fatigue may be holding them back from doing that. And so I think it's very important to have the basic information. And we've asked physicians before, like a lot of times would get called in to give lectures to emergency room physicians. And we would say to them, well, how much training have you guys had in the cognitive effects of brain injury? And they'd say, well, maybe an hour. So you can see where, they're learning all these millions of procedures and techniques, but brain injury is sort of a specialty area.
Right. And as a speech language pathologist yourself, what do you think are the key things that an SLP student or an SLP professional should know about brain injury?
Well, I think it's critical that they know not to push a patient beyond their physiological limits, and that it's not really a recipe book. You have to really look at the client and know them for who they are, what their goals are, and then correlate our goals in with that. But you can't just assign the things that would be sort of like a recipe book.
Yeah. Customized treatment.
That's right. That's exactly right.
And what strategies do you work on with the client to help them live well after brain injury? Do you work on eating habits? Do you work on exercise? Do you work on mental health care? What do you do to help them succeed after they leave your office?
After the injury? Well, we work on all of those things. And one of the first questions people ask is, well, what supplements should I take to improve my brain functioning? Well, we have names of individuals in town who can even do blood work and determine those things. We work with physicians on that. We work with registered dietitians and nutritionists that are very knowledgeable about brain injury. Exercise programs, that's the other thing, is that sometimes if someone doesn't understand brain injury, they will push a patient beyond their physiological limit, which will then scare the patient in terms of exercising. So we really tell people to start slowly, build up very slowly and very carefully in a stepwise fashion. And so we really try to make the family aware of those things, in addition to the patient, that people seem to have a lot of motivation to get better, and we love that. But teaching them to hold back a little bit and just enter things in one step at a time is part of the philosophy.
So that really goes back into that energy mapping that you do. It's really helpful.
That's right.
And not to, how not to burn out and how to use energy at specific times and pace it out for a duration of the day.
Exactly. And we teach pacing and different ways. Like I'm also certified in standard biofeedback. So I have relaxation CDs plus rapid relaxation techniques. So I teach patients what's called the Pomodoro method, where you do something for X number of minutes, and then you shut your brain down and shut your body down and try to relax, open your arterial system, warm your hands, do some things like that for just a minute. And then you can, resume.
So a lot of mindfulness-based techniques.
That's correct. Yeah. And correlating their symptoms with, sometimes it doesn't correlate with what you've done, but sometimes people will say to me, oh my gosh, I put 10 things on my calendar for today. And then I did them all, and then I was wiped out for 3 days. They may not see that correlation because that's what they've always done. So, and we do have paper pencil tasks where we have people list their activities, like going to the grocery store, riding your bicycle, blah, blah, blah. And then we have them assign what percentage of their daily energy does that take.
Mm-hmm.
And that helps to determine how much they can do in a day.
Very cool. I think this is something that even healthy people need to do. I think a lot of people comment overwhelm themselves beyond their own physical limits.
Right, exactly.
And do you do any work with your clients on happiness and how to be happy even after having a TBI?
We do a little bit. I think we could do a better job of that. I think happiness sometimes also revolves a little bit around energy, but we do some things on happiness, and we talk about happiness. We talk about some of the books out there by the Dalai Lama on happiness, if somebody's interested. We also work somewhat on humor, getting people to analyze funny stories and things like that will prompt humor. And there is a point, Dustin, where we really talk to people about they're just, having a brain injury, and what does it mean to have a disability or to not see yourself as having a disability. You can move beyond that disabled kind of thought process at a certain point in time. You have to acknowledge it in the beginning because you have to back off and take care of yourself. But then as you move through, you can really increase your happiness by not labeling yourself as that.
And what work do you do with your clients to help them avoid doing that?
I tell them, it sounds like a crazy idea, but as you're going along and treating people, and people can watch their improvements, and they know that they're getting better in certain areas, and they know the residual areas of deficit, that's fine. But then I just out and out talk to people about altering the way that they use language to talk about themselves, and also not paying so much attention to what people in the environment might think about a certain quality that isn't absolutely perfect, to let that go and see yourself as a whole person. There's a lot of things, but I've found that at a certain point, you'll know when it is in the treatment protocol, you can just talk to people about that. I mean, out and out talk about it and give them strategies on how to alter the way that they're thinking about things. I actually tell people, imagine you have a kaleidoscope and you turn it 3 degrees to see yourself as a different person. And it kind of works.
So cool. And go back to humor and brain injury. Do you find that there are certain aspects of humor that people with TBI struggle to comprehend and find funny? And likewise, are there ways that people with brain injury have difficulty making jokes or telling funny stories?
Right. Yeah, exactly. I think you're right on target with that. Clearly, you know that area. Yes, like things that require abstract thinking or are higher level language tasks like puns and things like that. So we actually train people in abstract thinking skills, and we have sets of exercises to work on that. And some of it we start with like sentence completions, like you can't teach an old dog new, whatever. And so we do lists of those. Then we move into thinkograms, which are, pictured objects with fragments of prepositions, and they have to fill in the concept. And once they practice abstract thinking for a while, that makes sense. Then we move into jokes, actual jokes, where the joke is there and it might be missing a part, and they fill it in.
So it seems like a lot of idiomatic speech work.
Right. Exactly.
Very cool. And going on with that, do you find that a lot of people with brain injury, they interpret idiomatic speech as literal?
Yes. Unfortunately, and sometimes that doesn't change, and sometimes it does. And sometimes they're hilarious. They see things before we do.
And with your clients that you work with that have brain injury, are a lot of them younger or are many of them older?
It's a combination, really. A lot of seniors now, and of course, living in the university town, we see a lot of younger clients as well. But they range over, really young, like even some kids, but on up to into their 80s.
And from your clinical experience, how do you help people with traumatic brain injury age gracefully? And how do you help them with the aging process so that they don't lose cognitive capacity due to aging and their TBI?
Right. It's, there's a lot of literature now that shows that having had a traumatic brain injury increases the chance of getting dementia. And it's very worrisome to clients. And what the literature actually shows, though, is that if people do computerized cognitive retraining tasks, it can delay that by as much as 10 years. And also, it slows the decline. And so I talk to people a lot about, there's a book by Eric Braverman called The Edge Effect. And he looked at like speed of processing in people as they age and with other things. And what he discovered is that we think it takes about 100 milliseconds to have a thought. And if by the time your thinking is slowed to 400 milliseconds, then senility actually comes around. So I spend time talking to people about if you want to really keep your brain sharp, continue to do the computerized cognitive tasks on speed of processing, flexibility of thinking, multi-tracking, working memory, which of course is just critical. And all of those things can be done with computerized tasks. So I, tell people which programs to do and they work on it. And that's the concept of slowing decline for all of us.
Very cool. And out of curiosity, if anybody, a therapist, has questions about maybe some things that they can do with their clients that have brain injury, is there a way that they can get in touch with you?
Sure. They can email me at mariannekeatley@gmail.com.